Uh, Hello, everyone. When I was learning how to be a school teacher, I learned that the best way to get people's attention is you start doing that. But another way is you just use a microphone. What? My name's Arthur Rose. I'm one of the members of the team, and today I have the privilege of introducing what we're calling the Lightning Talks panel, which will be talks so fast that you barely knew that they happened. The Lightning Talks panel is called Interventions Working with Shame, and we've got four, well, more than four, but five great speakers, four presentations, and in keeping with the lightning, you can tell that I talk very slowly, so I'm going to say as little as possible. I'm going to ask first Rebecca Lush to present Navigating Shame in Medical Museums. Rebecca Lush is the curator of the University of Queensland's Integrated Pathology Learning Centre, also known as the Pathology Museum. And I'll leave it at that. And thank you, Rebecca.
Lovely, thank you. I'm just going to share my screen. Okay, hopefully everyone can see all of that. Excellent. Okay, so hello everyone. Thank you for the introduction. Yes, my name is Rebecca and I am from the Integrated Pathology Learning Centre or Pathology Museum at the University of Queensland. I would have loved to have been there in person, but as I'm hoping you appreciate, Australia is very far away, big distance to travel, and unfortunately I just couldn't make it work. So thank you for offering a digital alternative. It's been a fantastic conference so far, and I'm looking forward to hearing more. So my presentation today is on navigating shame in medical museums. So before I go too much further, I do want to acknowledge that the work we've done is on the lands of the Yagara and Turrbal people, and we pay our respect to their ancestors and descendants who continue cultural and spiritual connections to country. Okay, so before I go too far into the topic of shame for today, I did want to start with some context for the museum, so that when I speak about it later, you have an understanding of where exactly I'm working at the moment. So we are under the Faculty of Health Medicine and Behavioural Sciences within the university, and we are also supported by the School of Biomedical Sciences. This year is our centenary, which I know we're quite a young collection, but still a significant milestone for us. We have our first specimen collected back in 1925, a segment of liver showing signs of tuberculosis. So from 1925 to last year was our latest donation. We've collected around 5,000 human specimens. I will say at this stage, we use the terminology human specimens in Australia. I know it's quite different around the world and different names for the potted pathology specimens. So just letting you know, at this stage, that's the term we use. So when the collection was acquired, really the priority was to support medical teaching. And we have this wonderful dapper 1938 first class in pathology image on the slide. And we know that this group of medical students did have access to a pathology collection to support their learning. And even one of the members in that photo, a gentleman in the front row, not the one with his arms crossed looking very happy, but another gentleman in the front row was actually Dr. James Vincent Dewick, who started our collection all the way back in the 1920s. So while we still do support medical teaching as a priority, we have moved towards more community and other interest group engagement. There is a point to why I'm saying this, I promise. So at the moment, we welcome around 150 secondary schools from Queensland and New South Wales into the museum each year, and they study either our human body or psychology programs. We also welcome about 80 to 100 nursing groups into the museum. And we have expanded into offering opportunities to undergraduate courses. So medicine at UQ is a postgraduate qualification. So we welcome biomedical sciences, law, sociology, advanced humanities, and just last week we had our first philosophy class as well. So while this expansion on our audience has been fantastic, it has also come with many challenges. And one of those challenges, well, quite a few of them, relate to the topic of shame, which I'll now get into. So I'm going to start by identifying the issues that we have within the collection and the museum that relate to the topic of shame. I'll talk through the problems that arise from those issues and then hopefully offer some solutions. So not a solution or the solution, but a few things we have implemented or are implementing in order to try and mitigate the risk and this feeling of shame that we know some students experience. So just a bit of a disclaimer before I continue, there will be images of human specimens in this presentation. No close-up images, more images of the museum containing some faraway pathology specimens in them, but just to let you know in case you don't want to view that material. Okay, so when I was putting together this talk, one of the first things I did was sit down and think about this idea of shame. It was a fantastic opportunity to actually consider how this concept and how this emotion kind of manifests in the space. So one of the first things I really wanted to tackle with this presentation is to look at how shame in education more broadly, so not just medical, but in different faculties, different schools, how it can manifest within our pathology museum setting. I then proceeded to write down a whole lot of questions that I wanted to try and answer, and then remembered it's a lightning talk, won't get through all of them, but I did want to share a couple of questions that I had that I will be covering later on. So the first question was, do students feel shame when they're within the museum? In short, yes. How can we tell? We talk to the students quite a lot. So not just our postgraduate or undergraduate students, but also our secondary school students. And while they might not use the word shame exactly, all of the kind of things that they describe do revolve around this idea of shame. We also want to know, does shame arise from encountering human specimens in a way that might depersonalize or objectify them, whether intentional or not? So those were some of the main questions that I wanted to ask. We also started thinking about this idea of shame versus shaming. So while people might have feelings of shame in the museum, what can we do in terms of supporting feelings that aren't shaming or supporting displays that aren't shaming? So just very briefly, when I started in the role, we had an exhibition called Prevention Better Than Cure. It looked at alcohol, smoking, and obesity, and it was quite a shaming exhibition. So it didn't quite appreciate the complexity of those issues, and it was very much these are things people do that then therefore make them bad, and this is what leads to the specimens you can see. So it was a very kind of simplistic approach. So the ultimate question though I ended up on is, what is our role in ensuring we mitigate feeling of shame, and do we keep it hidden or do we engage with it? So before I start answering some of those questions, what problems do we arise? What's the point of asking these questions in the first place? Why can shame be such a detrimental thing for visitors to our museum? So we are an emotionally charged collection. The word pathology literally translates to the study of suffering. So we know that every specimen in our collection relates to pain, suffering, and trauma, or trauma. And all of our specimens have stories shared on them. So people can read the stories while they're exploring the museum. We found that students are at risk of feeling discomfort, embarrassment, and guilt, or guilt when viewing such specimens. And again, this has been very qualitative. It's been with talking with students, sort of casually discussing what they have experienced whilst in the museum, that we're starting to hear these words come out occasionally. We also know that there are students who might not want to interact with the specimens to avoid these feelings. So we have had students in the past not want to come into the museum because they were a little bit tentative as to, oh, what if I see something I don't like? What if I see something that doesn't make me feel comfortable? And we want our collection to be an educational resource that supports many students. So we want them to come in and engage with that. So that's one of the problems that we've really tried when we get to the solution side of things to handle. So as well as discuss, there might be judgment. So for example, say a smoker's lung, someone might have a knee-jerk reaction of blame or judgment for someone's choices. And we don't want anyone leaving the museum feeling ashamed of having these thoughts, and also subsequent actions. So nothing dramatic with subsequent actions, more so the number one action that we do see might be, say, someone taking a photograph when they know they're not supposed to. So this feeling of disgust might then encourage them to take a photograph to show someone else, and we don't want them kind of sitting with that feeling later on when they might have feelings of guilt for doing that in the first place. Okay, so to finish off in the 1 minute I have left, how are we addressing these problems? Very quickly, we're implementing what we call trauma-informed object-based learning. So this is a museum facilitation where the object, or in this case a specimen, is centered in learning, and we use it to get different perspectives, to get students engaging deeper with the specimen and not having a superficial kind of look at the specimen. We also have the students engage with difficult conversations. So we want them to actually address the elephant in the room with these conversations, and we try and make it as safe an environment as possible. So everyone who comes into the space knows what they're about to look at, and we also ensure there are spaces within the museum for students to retreat to if they don't want to continue their visit. We get students to reflect through debriefs via assessment or class discussions. And last but not least, we acknowledge that the awe and curiosity that might lead to feelings of shame can operate with respect in this environment, and we promote this respectful engagement through our actions, not just our words. Okay, so thank you for listening. That was a very quick, 10 minutes goes so quickly. Happy to take questions at the end, but otherwise, thank you so much.
Thank you very much, Rebecca. That was exactly 10 minutes. So no pressure on the future speakers, but there's a high standard been set. Now, I'd like to introduce Mick Krasner, MD, FACP, Co-Chief Medical Officer, VP of Education at EmPRO, a medical liability company in Roslyn, New York, and Professor Emeritus of Medicine at University of Rochester School of Medicine and Dentistry, to talk about shame competence training and patient safety, an innovative course for practicing physicians.
Thanks, Arthur. So in a country where the word proper is used way more than my country, I decided to dress properly, but I don't see anyone else is dressed properly. I think it's okay. I won't feel shameful about it. So medical errors and malpractice actions are among the most professionally challenging experiences that physicians experience, and almost always associated with shame. And so what I'm going to talk about is a course on shame competence training with a large group of physicians that are insured by the company that I'm now, after I retired after 2 years from the University of Rochester, I'm now working as their education VP and chief medical officer. So we're the third largest writer of malpractice insurance company in New York State, 15th largest in the state. This was the name of the course that we created. Luna and Will were our content experts and really took a huge part in developing this course, which just was released May 1st. And we'll have, by the time June 30th rolls around, we'll have about 1,500 physicians having taken this course. And let's see, next. It's actually regulated by the New York State Department of Financial Services, and those who participate in the course get not only a premium reduction, but they also get excess layer of malpractice coverage from the New York State. So there's a huge incentive to take this course every 2 years, and it's a mandatory, in a sense, for these physicians. They want not only the excess coverage, but they also want a reduction on their premium. And so they don't want to be there. They don't want to take this course. Really, they really don't. They're having had to take a course like this in New York State, having practiced medicine there for 30 years. Every 2 years, I did not want to, kicking and screaming to this course. So, and there's two parts to the course, which I'll describe when this allows me to advance. There we go. The course has 5 parts to it outlined that takes about 3 hours. It's online. We also have a small live version. And then the second part is a home project that they have to complete. They're given 2 hours to do that. And probably can't see way in the back, but the parts of the course: emotions in healthcare, what is shame, how to effectively respond to patient shame, the impact of physician shame on patient safety, shame competent peer support, and then the home project. And there's a quiz and evaluation. This is what I want to talk about, is our evaluation. We did a retrospective pre-test, post-test design, and we were really looking at how confident the participants are pre and after taking the course in 9 domains. So what I'm going to share with you are results of their competency. And these are the list of them: avoiding inducing shame in a patient, engaging with shame, constructively identifying shame that's masked by other behaviors, identifying feelings of shame in another person, in yourself, reaching out for help if you make an error, recovering from a medical error, supporting a patient, and then supporting a colleague. So those are the 9 domains that I'm going to share these results for. So on the left side, you'll see that we'll have some demographics. Actually, let me go back. This population is an older population. What's happening throughout the United States, maybe throughout the world, is that more and more physicians are employed by health systems who are self-insured. So the private practice, so to speak, groups and physicians, at least in the U.S., are becoming an older and older demographic. Eventually, I think we're going to no longer have a lot of private malpractice insurance. They'll be self-insured by these health systems. So there's your age distribution. And then next is this is actually the distribution on their practice characteristics, how many people they share the practice with, that sort of thing. And then I had a specialty distribution. It's probably not all that interesting, but the majority of them are family practice, internal medicine, pediatrics, and then we have almost every subspecialty represented: surgery, all the surgical subspecialties, all the medical subspecialties, pathology, radiology, etc. Next. I get extra seconds for this clicker. All right, these are the results, and then I'm going to show them graphically just to give you a little sense of the statistics involved. We used the Wilcox-Sign rank test because it didn't assume any normal distribution. We never studied this kind of thing before. The effect size was calculated from the Wilcoxon test, and you can think of the effect size similar to a correlation coefficient. If it's 0.1 to 0.3, small effect; 0.3 to 0.5, moderate effect; greater than 0.5, large effect. And then to control for increased type 1 error, we applied a false discovery rate, and all of the results I'm going to show you have p-values of less than 0.001, every single one of them. So you can see those are the 9 domains. These are pre-post. Just visually, you can see, and across the x-axis on the graph is the different domains that we tested. And so every single one of them, and every single one of them associated. You know, we had an N in this sample size of over 700 physicians. We're going to eventually do this analysis at the end of June, probably on about 1,500 physicians. And then this is another way of looking at the effect size. Identifying mass shame seemed to be the most powerful, but they're all pretty significant. So I think this is really encouraging that you could have a brief online education and have this kind of effect. However, you know, there are some significant limitations. You know, it's this retrospective, come on, any day. There we go, retrospective pre-test, post-test design, which certainly makes a fair number of assumptions that they can actually say, ooh, how was I before I took the course? How am I now? And we don't know about persistence of this effect if we tested them a week later, whether there'd be any effect. And then actually, to me, the most important thing is how does this translate into their work? What do they do? Does it actually affect risk? This would be, you know, $1 million question, multi-million-dollar question in the United States. What does it result in higher quality of care and improved professional satisfaction? And I think that's it. There's my information if you'd like, or I have cards if you need any, if you want to get my email to contact me. And I think that's it. Thank you. So do I get to stand up for a couple minutes, or?
You can stand up for 3 more minutes, actually. You didn't even need the extra seconds. Moving quickly along, Patricia Luck, MB, CHB, MPhil, MSc, is Assistant Professor of Health Humanities and Bioethics in the Department of Health Humanities and Bioethics at the University of Rochester School of Medicine and Dentistry. And she's going to be talking about inclusive practice, mitigating shame in the clinical environment. Thank you.
I think I get mixed 3 minutes. Thank you, everybody, for having me here and present. It's wonderful to be here, having followed your research projects for the past few years. It's great to present. If there are any photographs on here that haven't been given any credit to, they're my own. I haven't stolen them from anybody, but I think very visually. So I always love having photographs in, and I want to thank Will, my partner in crime, with doing this workshop. We started thinking about, or I started with a colleague of mine, Beth Wellen, who was doing some mindfulness practice work with me, thinking through a shame project. We did an early kind of pilot, which we also roped Mick into for that. It all becomes a very small group here. And having gotten some really positive feedback from a bunch of friends and colleagues to say this is really important work you needed to do, we thought about presenting at a conference in 2019, and Will had just published some research material that someone pointed me to. In fact, Chris Mooney, who is our stats guy, helping with this, and I emailed Will and said, by any chance, would you be interested in coming presenting with us? And it's been really fun to work together since then. So we did a 90-minute workshop of this same thing I'm presenting today, and we, in this last year, 2024, expanded it to do a workshop over 4 hours. And of course, as you expect, people say it's just never enough time. 90 minutes wasn't enough time, 4 hours wasn't enough time. We're like, okay, you're gonna come and do shame for 2 days, 3 days, 4 days, you know. Inviting healthcare professionals to come and talk about shame is always a fraught topic, and I often feel a lot of shame talking about shame and giving these presentations, so I know asking people to come and explore this with me can be really difficult. So I'll describe this workshop, which is a mindful practice workshop, actually, which Krasner and his colleague Ron Epstein developed back in Rochester in 2008-09, and about 3,000 or 4,000 healthcare professionals have gone through a mindful practice program. We've tweaked it to think about it for shame, so thinking about it as an approach to really building foundational shame competency. I'll briefly give you some results, but you'll have to, I think, hang out for the paper for that. I'm not very good about speaking about stats and results, but it'll force me to write a paper, and then really think through some outlines. And I'm a palliative care doc by family medicine and palliative care doc by background. So this is, and I studied and worked in South Africa for many, many years. And I kind of really love this transformational image. Some of you may or may not know this is a scarab or dung beetle. And a dung beetle, what does it do? This is not a gym for dung beetles. This is actually laying eggs into elephant dung. This is elephant dung, and the transformational and growing your young. So shame for me, working with shame, is this potential for real growth, for looking at things that are really difficult, can be life-changing for healthcare professionals, can be life-altering in terms of their trajectory, into what they're thinking about for themselves, for their careers, for their identity. I'm not going to tell you about the shame research. You know all of that. But it's always a reminder, growth, new growth, transformation is really possible. And so we really think about this as helpful and creative ways to change shame constructively within the healthcare environment. My current work is working a lot with medical students across all, for us it's a postgraduate degree, years 1 through 4, and really thinking through and helping them think through how they're working with their own transformation of identity and professionalism into this ideal. And many of my students are experiencing shame and talking about it. And then, of course, in the patient life as well. This is a beautiful print that I came across looking for a print online done by a patient. And I worked for many years in HIV care, in pediatric palliative care. So shame experiences within patients is really, really pervasive and difficult. Arthur, you will give me a 1-minute notice. I tend to talk a lot. So really thinking about this mindful practice workshop. And so from the medical literature, we do know that clinician well-being and the quality of care and the quality of the caring are related to each other, and that through the mindful practice program, the research has shown that this kind of a workshop can impact how we feel about ourselves, the care that we give, and the quality of that. And it's based on really 3 technologies. One is an underpinning of mindfulness practice. So thinking through this capacity to be present with ourselves and with others in a particular way that can be non-judgmental, can really be aware of what's going on in the moment, and then thinking and working with appreciative dialogues, which in the medical world, we often start with the question of, so what's your problem? What brought you here today? What is wrong? And an appreciative dialogue kind of flips that in terms of what's going right. You know, I thought through with my palliative care patients, you know, why are you not being compliant or coming? And then I met a young mother who came with a really significant child with a recurrent illness. And I asked her one day, so why did you come today and not 6 months ago when your appointment was? And that today I came because I had transport money. And so I started thinking about, so what enables someone to come today? What was it? What helped you? What was the strength? So appreciative dialogue is, we work with healthcare professionals. What's our strength-based approach? And then through narratives, can we think through story and how we do that? And so in our workshop, we really started with, can we do the recognizing and shame? And I'm very fortunate to work with our content expert, Will Bynum, who comes and talks about this is how we recognize shame, how we work with shame and guilt, but also setting it up, especially within this clinical environment, a container of real psychological safety. You're not going to talk with colleagues, or if you're a trainee or if you're a medical student, with somebody else about your shame or your shame experience, unless it's really been set up in a way that you can do so. And so from our mindful practice kind of workshop perspective, we spend almost half the workshop doing questions. Can we have an appreciative question? What are the strength-based ways that you have worked with yourself when something's difficult? How do you share that with something else? So really working really hard on this appreciative container. And then we have a particular way that we have them tell their stories and listen to somebody else's stories, you know, have a reflective writing piece first, and then share with someone else. And the listening part of it is really often the therapeutic part. They'll come away and they say, I've never had someone listen to me in this way without feeling judged, without feeling like there's something wrong with me when I'm speaking about my own shame experiences. And then we weave short, you know, often these are short workshops, so brief mindfulness practices throughout. Our intention is not to have a seasoned mindfulness practitioner, but for the mindfulness practice to be a container that we all can feel supported. And of course, the research around compassion and self-compassion really supports that. Feeling compassion for self and for others can be effective with these workshops. This slide just shows you that we had 35 participants in this particular workshop. And this is kind of my favorite slide because some of the earlier research in doing shame work with trainees and with clinicians was that talking about shame really recapitulates this feeling of feeling shame. And we had this in our workshop too, that participants said, you know, it was really hard and difficult and shameful for me to speak about it, but it was especially helpful to see that others were struggling with the same thing, that it really helps decrease the sense of isolation, of loneliness, that it's not just me, it's not just, oh, I was wrong, there was something wrong with me, but an understanding that this is a systemic thing. And so our psychological safety was, you know, from moderately quite to extremely safe was, you know, all the way up to 100%. And then happily for us, the effectiveness of the workshop was also well supported. And then these are just slides to show you the bottom line. This is also retrospective pre and post workshop survey, thinking through how was I, in terms of how good was I at identifying a shame reaction in myself, in others, sharing these feelings with other people and actively listening to a colleague. The lower line are the means before the work, assessing before the workshop, and the upper line after the workshop. I'm interested that the lowest point on this graph is feelings of shame with others. That's always the most difficult. It's easier to identify shame in myself, not so much in others, but sharing it is really hard. And this is my next slide, yes, recognizing and recovering, and the lowest point is recovering from shame. And so those are really these more fraught areas. And this is happily that they'll use mindfulness as a resource. And then our lessons learned, this is one of the biggest volcanoes at the DRC. And so I think this is, if we look at shame, it's this volcano sometimes that's about to erupt. And the lessons are learned are really what I shared, is that we need to do more of this, that it helps build community for ourselves, especially within the healthcare work. If we feel less isolated, less alone, less fraught, we really can work better with each other as colleagues and work with our trainees. I'm especially worried, concerned, compassionate about the trainees that we work with. Come and talk to me with questions. Thank you.
I'm hardly having to be brutal at all. For our final talk, I just wanted to say at the end, as you'll have figured out by now, we're going to do a round table for all of our speakers. Our final talk is Gioconda Mojica and Madison Brenner of the Houston McGovern Medical School. Dr. Mojica is I think the site director for the surgery clerkship subspecialty elective in ophthalmology. She also mentors students both clinically and in their career development. Thank you.
Well, good morning, everyone from Houston, Texas. My name is Madison Brenner, and I am a fourth-year medical student at McGovern Medical School, and I am so excited to be able to share our work with you all today. So throughout my training, I've really come to value the concepts of shame awareness and self-compassion, both in my own journey and in supporting my peers. Recognizing that these topics are rarely taught in medical education, we were really motivated to help create an interprofessional elective that would give students from across the health professions a structured and safe space to explore these ideas together. We were also very fortunate to have received a Josiah Macy Jr. Foundation President's Grant to support this initiative, and today we are honored to share our findings that are currently under review for publication. So we designed a voluntary 6-hour extracurricular elective called Fostering Connection and Shame Resilience Through Self-Compassion that was open to students across our medical, nursing, and dental schools. Each of the 3 sessions began with a shared dinner to foster connection between participants, followed by a short period of large group conceptual learning. We then transitioned into a reflective writing exercise using pen and paper, and then collectively participated in a guided self-compassion practice. Each session ended with a small group discussion facilitated by a faculty familiar with the concepts that we discussed that day. These small group discussions provided a confidential environment for learners to be able to reflect on how the session content related to their own personal experiences and to foster connection via peer and faculty support. During the small groups, 5 discussion prompts were developed to encourage active engagement and meaningful dialogue. This format was intentionally chosen based on the observation that learners feel more at ease when discussing sensitive topics in smaller and more intimate groups. So here's an example of the conceptual learning that we would present in the large group portion of each session. We would teach that self-compassion is the antidote to shame. Self-compassion, according to Dr. Kristen Neff's definition, is the opposite of shame. Common humanity is the opposite of isolation, and it reminds us that we are not alone in our struggles. Our experiences are often shared by others. Mindfulness is the opposite of over-identification. It helps us look at our difficult situations and our mistakes with a balanced awareness. And finally, self-kindness is the opposite of self-criticism. It reminds us to set our intentions to respond to ourselves and our experiences with kindness, similar to how we'd respond to a close friend. So here's a picture of one of our student leaders facilitating a reflective writing exercise. And here's another picture demonstrating how our participants would separate into small groups for discussion. We use validated measures for the study, Dr. Kristen Neff's self-compassion scale and Dr. Will Bynum's shame frequency questionnaire. A control group of medical students who did not participate in the elective were invited to email to complete the shame frequency questionnaire to enable comparison between these groups. We also gathered qualitative feedback from our participants. All data gathered through surveys was fully anonymized to ensure the confidentiality and privacy of our participants. And with this structure and evaluation approach in place, we were interested in understanding whether this elective would meaningfully impact our learners' self-compassion and experiences of shame. And now I'll share some key findings from our results. A total of 24 participants enrolled in the course and 21 completed the anonymous surveys for a total of 87.5% completion rate. Demographics for the participants who agreed to complete our surveys are summarized in this table. 90% of our participants attended all 3 of our sessions of the elective, with the majority identifying as female. 6 faculty participated in total, with 5 from our medical school and 1 from the nursing school. We found that participation in this elective was associated with meaningful improvements in self-compassion. Learners showed significant gains in 7 in the 12 individual items of the self-compassion scale and in 4 out of the 6 subscales of the self-compassion scale: self-kindness, self-judgment, common humanity, and mindfulness. Overall, the group's self-compassion score increased from low self-compassion prior to the elective to moderate self-compassion at the end of the elective. Here's some of the items from the shame frequency questionnaire for the medical students that participants took at the end of our elective. The questionnaire asked the following questions. During the past 3 months, how often have you experienced the following thoughts and feelings? Deficient as a person, unworthy to be in healthcare, not smart enough, like you don't belong in healthcare, are just some of the examples. Although the total shame score did not differ between the elective group and the control group, item level analysis did reveal significant differences in 6 out of the 12 items between elective participants and the control group. This finding suggests nuanced shifts in the shame-related beliefs and experiences as a result of participation in this elective. We also gathered qualitative feedback assessing the effectiveness of the elective using an anonymous survey. We asked them, how has your openness to practicing self-compassion in challenging situations evolved after participating in this elective? 89% of the participants reported moderate to significant increases in their openness to practicing self-compassion in challenging situations. We asked, to what degree has your awareness and understanding of shame evolved after participating in this elective? Almost 95% of participants responded that they had moderate to significant increase in their awareness and understandings of shame. "67% of participants reported that the elective helped them feel significant or moderate improvements in their ability to cope with shame in a more constructive way, instead of letting the experience of shame become debilitating." We also asked our participants open-ended questions. One of the questions was, how has this elective contributed to your personal and professional growth as a health professional? They replied, it was not only insightful to learn about shame and self-compassion, but the tools we learned, such as slowing down and deep breathing, are tools I'm eager to incorporate into my MS3 year during rotations. I learned more about not isolating and including myself in the common human experience of shame, that I am not alone in my feelings and can connect with others as a way out of a shame spiral. Another participant wrote that I enjoyed connecting with others who shared my thoughts and experiences. I also enjoyed learning about why healthcare professionals may feel the way that we do and ways to handle it. In summary, if shame presents itself in our health profession's journey, self-compassion is a powerful antidote. This elective offers a model for integrating shame, resilience, and self-compassion into health professions education, concepts that may be overlooked in traditional curricula. The combination of brief conceptual learning, reflective writing that actually uses pen and paper, informal self-compassion practices, and small group discussion created a valued space for learners to explore their identity, belonging, and well-being. We observed significant gains in self-compassion and item-level shifts in shame-related beliefs, suggesting that even brief interventions can foster meaningful changes in learners' self-perceptions and emotional resilience. Students consistently valued the opportunity to connect with peers, reflect on personal experiences, and learn practical self-compassion skills applicable to their clinical training. I'll leave you all with a reminder that if your compassion does not include yourself, it is incomplete. Thank you for this opportunity to speak with you all today.
If our two in-person people want to come to the front. I should say, I apologize, Madison, for not introducing you and for failing to actually read out your title. In the words of Samuel Beckett, I'm failing better. Does that work?
Yeah, that's fine.
So I think what we'll do is we'll do questions from the floor and then online and then from the floor. Anybody want to go first?
Hello, I'm Andrew from King's College London. Right. So my first question is for Rebecca, who's way up there in the dark in Brisbane. So I assume Rebecca can hear me? Yes, no,
yes, I can. Yeah.
Yes, good. I was just wondering, I'm just reflecting on the times where I've gone to the Wellcome Museum, where an anatomy museum in Guy's, where they have all these many specimens there. And I was just wondering, I did feel much shame, actually. I was just feeling a lot of queasiness. And so did all the other friends I brought along to those museums. So I was just wondering, did you mention the word discomfort, embarrassment, and but was shame measured in any questionnaire? I mean, sometimes interviews can be difficult depending on how you do your thematic analysis.
Yeah, excellent. Thank you for your question. Yes, I will definitely preface this by saying it's 10:50 p.m. where I am. So if I don't give a coherent answer, I blame it on the time zone. So it's a really interesting question because it is something we haven't measured, and it's something that we haven't used kind of the language surrounding. So this presentation, I'm using it very much as a starting point. And I think the next step logically is taking those kind of qualitative anecdotal stories that we've overheard and actually doing something formal with that and doing some kind of qualitative research and interviewing students. So you've picked up on a really good point, and hopefully, I don't know, if this happens again in the future, then yeah, we might have some results on that.
I don't think do we have something online?
Just for the first speaker, the financial incentive that you described for the participants in the program. I was wondering how you convinced the insurance company to provide that.
It's a bit of a complex answer. You know, there's been a lot of what's called tort reform legislation, at least a movement on tort reform, because malpractice is such a huge cost, at least in the United States, and I'm sure in many other places. So about 25 years ago, New York State decided to address that in the following way, that they would actually take taxpayer dollars to provide an extra layer of coverage. Several $1 million of coverage to a physician's malpractice. And they would pay insurance companies to have the physicians take this course with the idea that it would result in risk mitigation. So there's a huge, is that me? There's a huge incentive for the company. The company actually gets taxpayer dollars. It's kind of crazy. For every physician who takes the course, that gets this excess layer of coverage. So there's multiple incentives. So the company gets money. The company passes some of that along in terms of premium reduction to the insured, and New York State ultimately pays the company and pays for the extra layer of coverage. So the idea is that one of the negative effects that this has happened is that because of that extra layer of coverage, when a lawsuit occurs, the plaintiff's attorneys know that they have that extra coverage, so they inflate the reward demands to reflect that. So it's kind of a vicious cycle. It's pretty insane, if you ask me. And luckily, I was just brought in to really develop education programs that I think would work and that are creative, like Will and Luna, that's helped us provide this incredibly creative program. So, but great question.
Hello, I'm Vrinda Naik from University of Exeter. I think what I'm going to ask may be applicable to all speakers. I believe shame is a feeling that is sometimes influenced by, or often influenced by, the cultural background of the person. I wonder whether in any of the data analysis that you have done, whether you have considered the cultural background or any other personal characteristics of people who responded to your workshop or the interventions or the questionnaire. Thank you.
Thank you. That's certainly a good question. But this is not something we looked into with our particular workshop. We didn't even ask any demographics of the people that attended, other than they attended the workshop. And we know that those who came to our workshop were healthcare professionals, trainees, or students. Yeah.
Yeah, we don't stratify people based on whatever demographic. We don't measure, say, Neo5 personality domains. But I will say something about your work, Trish, is that in the mindful practice literature, we actually did an original pilot study, it was reported in JAMA in 2009, and it attempted to look at what kind of people would respond to a mindful practice intervention in terms of personalities. So we thought it would be a moderator in our moderator analysis, that if somebody had, high neuroticism or something, that maybe they would respond in a certain way. We didn't find that, but what we found, unbelievably actually, was that 2 of these 5 personality traits, considered standard traits, actually improved. And these physicians in that original study were in practice about an average of 17 years. You'd think these were traits unamenable to change, but they were conscientiousness was one of them, and I forgot what the second factor that changed. So I think there may be some effect of offering a workshop in this kind of context like Trish offers that actually could help strengthen certain personality domains that could be maybe help mitigate some shame experience.
Rebecca, Madison, Gioconda?
Yeah, I can answer that. I think definitely the culture from our experience absolutely does play into a person's experience of shame. In our study, we did not look at the cultural impact. We did have some demographic data in terms of looking at how the participants identified in terms of male or female and academic year, but we did not look into cultural contexts.
Yeah, I have a question, if I could, Rebecca.
I think Rebecca, did you want to respond, Rebecca?
Oh, no, I'm all good. Thank you. Thanks.
Great.
Okay, sorry. Yeah, Rebecca, I had a question. I don't know if many of you have seen that traveling exhibit now about 12 years old of the anatomic lucite cuts. Do we know anything about how the public has experienced that in terms of shame? I'd be interested in that, if there's anything written about that.
Yeah, it's an excellent question. So the exhibition might be Body Worlds that you're referring to, which interestingly is opening tomorrow in Brisbane. So we are getting that exhibition to the city. I don't know if there's anything that has been written about it, but I know that through discussions with medical students in particular and our undergraduate students, there has been a bit of a, I'm not sure if I'd use shame, but there's certainly been some response to when we're kind of discussing the ethics of this exhibitions and how it's a little bit sketchy at best with terms of ethics. There's definitely a response there, a big response of guilt for maybe purchasing a ticket. But in terms of broader kind of public ideals of shame when they're looking at these kind of exhibitions, I don't know if there's any literature out there, but it would be a really interesting area to look into.
Sounds like a very short time period to get a IRB approval for this exhibit, huh?
Absolutely.
There's a question or comment online from Becca, which I think is for Mick. So she writes, there must be an intrinsic relationship between shame and litigation due to the nature of blame involved. And she says, I'm thinking of restorative justice as a competing method. Comment for comment.
Yeah, I 100% agree. Certainly, yeah, because I mean, the opening speakers that so brilliantly outlined through kind of an organic process of this professional, what do they call it? Professional project. Yeah, that to make a mistake or to be perceived by others as making a serious mistake that causes harm to someone just goes against just about everything that professional project has us work toward. And so it's intensely shaming to make an error, even if it doesn't result in any kind of legal action, but to then have an action, have the public, the legal system, sanction you because of that. That's really, so I think a different kind of, there's a number of different ways of managing these kinds of things, and restorative justice certainly is one of them that would be, I think, really helpful. So I agree.
I'll make this make this quick. This is for Gio and Madison. Hi, this is Will Bynum. So good to see you. Thank you so much for using the questionnaire. It's the first time it's ever been used. Granted, it was just recently published last year, but I was sitting over here on the edge of my seat to see what would actually work with it, and then it didn't really show anything, and I thought, gosh, did we just create a broken scale? On the other hand, that's not how science works. So it's possible, I was thinking about, well, I wonder why maybe you saw some individual level item change, which might suggest some nuanced changes in shame frequency, but the overall scale didn't change. And another possibility I'm just interested in your thoughts on is that, and I would say this is maybe a testament to your approach, that the approach didn't necessarily change shame frequency, but it changed how it was responded to. And I wonder, were you expecting to see changes in shame frequency or experience of shame based on what you did, or was it primarily oriented towards how it was responded to?
So nice to hear your voice. I'm sorry we can't be there in person. It would have been wonderful to have met you, Will. So thank you for that question. We were hopeful, of course, that we could see some change overall. We do know that it is a complex emotion that, can start as early as the toddler years. And so we're talking about decades of how shame can impact us from so many different ways. We did compare our participants to a control group. So I believe that, there's a possibility for seeing some improvements in the overall shame score, perhaps had we done a pre and post within the same group. And then also increasing our numbers. We had 21 students or participants complete the shame frequency questionnaire. And so we're excited because the qualitative feedback was so great, and the improvements in self-compassion, and even as you mentioned, the item level improvements in shame were all the findings from our study were so positive. We're actually going to repeat it again next year, and we'll reach out to you and let you know how that iteration goes.
I have a question. That's all right. This is for Mick. You alluded to the multi-million-dollar question, which is whether doing an intervention like a shame competence training could lower litigation rates. Is there a way to measure that with your physician group, like looking at litigation rates over? Obviously, this is a self-interested question. Can we find out?
I think we know 100% that this particular program, we've produced many programs over the last couple of decades, but this one, of course, will have that effect, no problem. But it's very hard to attribute, a malpractice action that's made and then until it eventually gets litigated, on average takes 4 to 6 years. So it's a really hard sort of timeline to really attribute a change and then to watch for that length of time. So I think there may be other surrogate markers one can look at, including sort of mining claims data and see what kinds of treatments, because you can tell from claims data what treatment was recommended for certain conditions, and you can look at higher quality medical prescribing, for example, versus lower quality, and so as surrogate markers of lower risk practices. So I think that would be the tack to take, is see within a period of time after taking a course like this, is there some surrogate markers that show improvements? I think that would be pretty powerful, really hard to, and also the secular trends of malpractice actions are just so, they're all over the place. They fluctuate so dramatically, so.
Can I sort of follow up? Can I follow up on that? Because we've started doing some work from this on defensive medical practice, and I suppose one of the areas that you might actually find it. So our, I suppose, hypothesis is that post-adverse event, that shame actually is what motivates defensive practice, and that what you might not necessarily see are changes in litigation rates, but actually preventative measures that stop people from sliding into defensive medical practice.
That's a great idea. Yeah, thank you for the reminder. I mean, overutilization is a huge area of interest in medicine for many reasons, including costs. And I think one could almost hypothesize, in maybe there's already literature you're familiar with, after an action is commenced, a malpractice action, is there increased overutilization of resources, over-testing, et cetera, those sorts of things, because of that uncertainty in one's an individual agency in practicing medicine. And if one can, and that would be a great marker of practicing less defensive medicine, and hence, you know, maybe a more higher quality. So.
Thank you so much. Thank you so much for this, all these really interesting presentations and for the workshops. And something that was said earlier on in terms of nobody wanted to do these workshops. Shame is such a difficult emotion to deal with. And how did you, I know that one of the speakers, there was a financial incentive to do the workshop. How do you get people who want to avoid these emotions to become informed?
I think that's a really good question, and that's maybe the second $1 million question, because many of the people who came to the workshop, they self-selected, right? They wanted to come. They were invited to come. They came because they knew me, or they were within a network that this was recommended, or they were at a conference and they had a personal connection. And we certainly had people at our earlier workshop that talked about, no, this is really, I don't do shame. I never had shaming in my medical education, and then I happened to see the same person as a healthcare provider in the same breath as seeing them in my clinical encounter. They proceeded to tell me that they were being pimped by a which is not a word that I was familiar with until I came to the US. And so any kind of questioning, or, you know, kind of second guessing, or being made to present information in front of peers, or certainly within a hierarchical structure, is called pimping. So I was like, oh, you're not being shamed, but you're being pimped, and that's the. But some of it is hard even within medical education, because I have colleagues who are directors of fellowship and residency programs, and they're noticing the importance of talking about shame within their programs, but then doing the next step in terms of having the work offered can be very difficult. I've recently done a narrative session for psychiatry residents talking around shame, and this was just a required course, or a required 2-hour session for them to come and talk about shame. We worked through a text that we then discussed. It's very difficult to approach that. There was a lot of denial and about their experience of shame, and then dismissive of others' experience. And so I think this is slow work. It's incremental work, and it's work over time, that if more of us step into the space, if we talk about it and talk about some of these experiences, and then the research helps more and more to show the detrimental effects on ourselves, on the system, on the whole kind of complexity of the network. It's like show up for a workshop on pain and suffering. Nobody comes to that either.
If I can speak briefly just from a student perspective on this, I think I've really noticed a big shift, and how this younger generation is really truly pursuing education on this topic, and they're trying to have almost a mindset shift and culture shift. And I think this workshop that we implemented really gave us an opportunity to learn about this and ways to approach kind of the pimping that you unfortunately mentioned, and these shame-filled situations that we experience in medical training, and how we want to change it for ourselves and for future practicing physicians. And I think it's also very important that we have faculty that support us. I felt very grateful that we had mentors like Dr. Mojica and other notable faculty that were willing to be vulnerable with us in these sessions and talk about feelings of shame and how they handle it, even in their professional careers, and advice that they have for us. So I think having kind of the mutual respect of our attending physicians as well, being willing to talk about it, means a lot. And I think that it's kind of the younger generation of physicians really wants to change, and I think it's moving in that direction. So from a student perspective, I think we're all really eager to start incorporating lessons like these.
There's a comment online from Caroline who says, just validating Will's point, I think a success could be working through shame more quickly with less residue and not necessarily experiencing shame less often. And I think introducing these concepts is like planting seeds that may grow over months and years. She also says, I've been doing a mandatory session for all first-year family med residents, I think at McMaster in Hamilton, Ontario, and using Will Bynum's resources has been pivotal.
I believe in the UK that's called impact. I know that we had one last question, but can I ask you to phrase it a little break, or do you want to make it a lightning question? Because I don't want to tread on people, if that's okay. In which case, the last thing is just to thank our speakers. Thank you very much for those.
Thank you.
Who got up early in the morning, who stayed up late at night and came in person. Thank you very much, and enjoy your break. We'll start at 25 past. Or we're going to start a bit later. Okay, that's fine.
So the last speakers unfortunately had a family emergency cancelled, so we have a half-hour buffer now, so we're not.
Okay, well, in that case, do you want to ask your question after that? No, we don't have a buffer. Okay. At this point, you're seeing kind of, yeah, no buffer. Okay, I'm just going to stop there. Thank you very much. So I think the break is for 15 minutes, which will get us back at past.
So next, here we have Dr. Sarah Malanowski and Dr. Nicholas Baima from Florida Atlantic University, and they'll be talking about shame in anti-smoking and weight loss campaigns and addiction. What can we learn?
Okay, so I'll get us started. So you can go to the next slide, Sarah. So, click again.
Okay.
Hit it again. Okay, so I'll start with some of our previous work. So in a previous paper, what we did is we examined the empirical and ethical use of shame in public policy and scientific communication. So the examples we looked at were mask wearing, vaccines, smoking, climate change. And the thing that we were really focusing on is how shame relates to trust in science. And I think the unique or novel point that we made was that there's an important distinction between communal and non-communal shame. And the basic idea is that within communities, these can be big or small, but it's possible for respect, compassion, understanding, and trust to take place, and this is just really not possible in non-communities. And this allows for shame to be better received in communities than non-communities. Next page. So related to this, so a non-communal setting would be something like a government or energy company promoting a policy through shame, or where shame plays a role. Well, it risks being poorly received, backfiring, and also being unethical. However, while communal shame can potentially avoid these pitfalls, the shame risks being more devastating since one is being shamed by one's community. So today's talk, we're going to transition from focusing on that to anti-smoking and weight loss campaigns. The motivation is that the use of shame in weight loss campaigns is often defended by appealing to the alleged success of utilizing shame in anti-smoking campaigns. Additionally, since smoking and overeating are often linked to addiction, and shame plays a critical role in the addiction recovery, it is important to consider how shame influences the recovery process. So our approach is basically empirically informed philosophical analysis, and we're going to focus on what the communal, non-communal aspects where we see them relevant to continue on our previous work. So our general thesis is balanced. While evidence indicates that shame can be a powerful motivator, overt shaming practices employed by public health entities raise serious practical and moral concerns. Accordingly, we're going to argue for a modest degree of implicit shame associated with unhealthy behavior when paired with compassion, trust, and understanding. We're going to say that can play a constructive role, especially in communal settings of mutual trust and respect. Go on. However, this isn't an endorsement of explicit shaming practices. This is a basic overview, and so I'll start with anti-smoking. So we start with, there was this study done by psychologists to explore what emotions would most effectively grip smokers and help them quit, and they found that shame would be it. And so with their help, this commercial was developed, and it's over on the right. We're not going to play it, but essentially it really draws your attention explicitly to shame. So it'll be like, is this how they see you? Is this how your friends see you? Is this how your kids see you? And then it ends with, is this how you want to see yourself? So that's an example of explicit shaming through an ad. But we also have implicit shaming practices. So a smoking zone would be this, right? So this isn't intentionally aimed at shaming, but it has result in feelings of shame. These are examples of soft stigmas. So they reinforce the stigma of smokers as unclean, undesirable, without explicit blaming and shaming. So what does the evidence say? Well, ultimately, it's pretty difficult to determine the precise impact of shame on reducing the overall smoking population, since a multifaceted approach has been taken. On the one hand, though, it seems reasonable to conclude that shame has played a role in the denormalization of smoking. So it's, keep going. We also see and support longitudinal studies showing that stigma reduces smoking. However, on the other hand, it seems like there's just evidence that also points to stigma and shame backfiring when it comes to smoking. So recently, Cortland et al. Found that those who identify most with smoking are less likely to quit when presented with stigma. Additionally, there's, need to be careful about minority and marginalized groups because they're especially vulnerable to stigmatization. So advertisements in these communities is more prevalent. The communities lack the resources for quitting, and the rate at which minorities are decreasing smoking is less than non-minorities. However, it is still true that smoking has declined overall within most minority groups. In addition, the claim that stigmatization and shame backfires in smoking needs to be balanced against the wealth of evidence that points in the opposite direction and what we know about self-congruency in marketing. So it's a little bit confusing because just for every, it seems like the evidence just is extremely complicated, and it's really hard to pinpoint when and where and how exactly the shame will be effective. So there's just too many variables to go through in this short talk, but focus on a few positive things that have played a role in conjunction with shame. This would be self-affirmation, autonomy, and control. So self-affirmation is reflecting on personal value, strength, self-worth. It's found that this can actually improve quitting smoking in the face of stigma. Beliefs about self-efficacy, like the possibility of success and the role you play in it, also improves quitting. And then self-determination theory in quitting, which is more individually directed, like what role you play as an individual, and gives you a feeling of autonomy. And combining smoking cessation with cognitive behavioral therapy has been well received and has improved quitting smoking. So the evidence, like putting this all together, the evidence likely points to shame playing some role in the reduction of smoking, even if there are instances when it can backfire. So we see this with the denormalization process, which relied on evoking negative emotions and attitudes towards this behavior, which likely induce feelings of shame. And this denormalization process has been largely successful. However, this doesn't mean that explicit shaming should be used, as there are other potential detrimental effects. It's difficult to control who and how one will feel in response to the messages, and it kind of creates a mob rule. So anti-smoking messages should also include various positive affirmations and support. So those are just some general conclusions. Now Sarah's going to take over.
Yeah, so as Nick said, the smoking campaigns have actually been quite successful in decreasing smoking rates. But now we have a new problem, right? So obesity is now on the rise. And so we see a great increase in obesity around the world in all sorts of different countries. We see it in adults, and we also can certainly see it in children as well. And so this has been a point of concern for many countries across the world because excess weight is associated with all sorts of negative health risks and has a lot of economic impact as well. And so this has basically prompted a response from governments and public health organizations worldwide. So we get the World Health Organization declaring that obesity is one of the greatest public health challenges of the 21st century. And in the US, the armed forces and the CDC have declared that obesity is actually a national security threat because obese recruits are unfit to fight. So there's a lot of concern about the rise of obesity. And so because of this, there's been all sorts of public health initiatives being deployed in an effort to stop and hopefully reverse the rise of obesity that's been occurring. And so in many ways, the approach to fighting obesity is taking cues explicitly from the fight against tobacco use and its success. And so, we could see why, because the goal is to change behaviors that are common in life, and that's very difficult. And so we're looking to the success of the decrease in tobacco use as inspiration. And so education, legislation, taxation, fear, along with disgust, shame, and social pressure are all tactics that have been proposed, endorsed, and used in this so-called war against obesity. And so there's been some academic argument in favor of shame tactics when it comes to obesity. So the bioethicist Daniel Callahan, for example, argues that in order to succeed in combating obesity, an edgier strategy is needed, one that's explicitly modeled off of the great success that came from stigmatizing smoking. And so he says that was so successful because it was able to turn what had been considered simply a bad habit into reprehensible behavior. And so he thinks that the public health approach to obesity should bring strong social pressure to bear on individuals and persuade them that excess weight is not socially acceptable. And then similarly, we get legal scholar Greg Bloch arguing that we should use shame in obesity campaigns because it's going to give a boost to motives, perceptions, and understandings that oppose immediate temptation of unhealthy foods. And so he thinks that this is going to basically change our social mores and our norms towards embracing healthy behaviors and avoiding unhealthy ones. And so shame's going to play a role in kind of like reshaping our whole social thoughts about food and eating behavior. And so we've actually seen some campaigns have followed suit on this and employed tactics that are meant to intentionally evoke negative emotions like shame. So one notable one is Atlanta's controversial Strong for Life campaign. So it was like stop sugarcoating it, Georgia. And so I have some examples there on the slide of what that looked like. And people really didn't like this. So it was meant to be harsh, right? That's, the idea was no one's gonna listen if it's not, harsh, the stop sugarcoating it. But people found this to be too stigmatizing and too shaming. So Rebecca Poole says, childhood obesity is absolutely a public health problem, but really ads like this just make the problem worse. When people feel stigma or shame, it only reinforces the behavior that leads to obesity. And then we have the public also being upset about it as well. Most campaigns aren't explicitly negative like that, though. So most are actually meant to just be informational or educational about healthy foods and the risks of obesity, or trying to provide more understandable nutrition information, or just kind of positively encourage making healthy choices. However, even these types of campaigns have been criticized for causing shame. So they utilize what Brewis and Witches call soft stigma, so in order to motivate behavioral change. And so although they're not overtly blaming and shaming, the idea here is they're emphasizing the importance of an individual's choices and their responsibility in avoiding obesity. And because they're focusing on individual responsibility, critics say that this is like reinforcing stigmatizing beliefs that if a person is obese, it's because they're lazy or gluttonous or they're making poor choices, all these things associated with obesity stigma. And so these things in turn then cause feelings of shame when these public health messages are encountered. And so there's been public and academic outcry over even the informational soft stigma obesity campaigns and saying that they're fat shaming, even though that's not the intention of the campaign. And so some research has shown that they might actually be perceived as being stigmatizing. So they impose like a psychic tax that makes people feel anxious and ashamed. And even just using the term obesity in a campaign can provoke judgmental feelings and anxiety. And so the criticism of these soft stigma obesity public health efforts is actually strengthened by showing that when people feel when their weight stigma is activated, they tend to they tend to basically start doing self-defensive behaviors that promote further weight gain. And so these stigmatizing campaigns are thus argued to be ineffective at curbing obesity because the psychic tax they impose basically causes people to just gain weight and not lose weight. And so the policies in general are unjustified because they're not even having the positive benefits that they are supposed to have. Furthermore, just like with smoking, marginalized communities might be more negatively impacted by obesity stigma, and so we might get this kind of like a sense of injustice of them being more affected by these campaigns than others. And so critics of anti-obesity public health campaigns basically argue that there's too much focus on making it the individual's responsibility to change. And so instead of doing these campaigns that focus on what individuals can do to change, instead efforts should be made into making structural changes that address inequality and obesity stigma. However, there could be some benefits to using shame tactics in the war against obesity. So the data on the negative effects of these campaigns is mixed. So some studies show that they're perceived to be motivating and effective. And a lot of the examples of soft stigma, like providing clear nutrition labeling, this is just important information for consumers to have in order to make rational choices. And so even if they do impose a psychic tax, they still could be justified putting this information forth, especially given the amount of persuasive, unhealthy advertising consumers have to face in a day-to-day basis. And so, although there's many societal factors that affect eating and exercise behaviors, it still is the case that the most proximate cause does lie with individuals' day-to-day choices. That's not to say that there are not structural changes that should be implemented and are important to consider. But just like as we saw with smoking cessation, beliefs about self-efficacy and autonomy do play a role in behavioral change. And can even turn shame into an effective motivator to change. And so personal responsibility should still play some role in public health messaging, even if it does intentionally cause feelings of shame, because this is going to be important to motivating positive change. And so you still might wonder, like, if we accept the use of stigmatization in public health measures against smoking as being ethical, and it does seem we have, does this mean that we should accept it for anti-obesity measures? And I think that there's some important relevant differences to consider between smoking and obesity. So eating is necessary while smoking isn't. Weight and weight-related behaviors tie to self-identity in ways that smoking doesn't. And so these are all factors to consider that could amplify the negative shame-inducing effects of stop stigma compared to anti-smoking measures. But it's also the case that eating is a very social activity and it's tied to community and bonding in ways that smoking isn't. And so this actually means that shame might be a more effective means of changing behavior when it comes to obesity than smoking, because the communal norms are going to have to be changed in order for the obesity epidemic to fall, right? And so we see, for example, in South Korea, weight stigma and shaming operate more explicitly and communally, and they do in fact have some of the lowest obesity rates. But the question then is, how do we do this in a way that effectively motivates behavioral change without causing too much harm? So can we leverage communal shame in a way that doesn't harm too much? And so this is where we can kind of look to the addiction literature for perhaps some clues of how this could be done. And so shame is very common emotion in substance use disorders. And so it's often argued to be an impediment to recovery, but sometimes it does aid recovery. And in fact, it's been argued that what matters is how shame is directed. So is it directed in a positive way? And so the authors Snoke, McGeer et al. Argue that there's a difference between retributive self-blamers and scaffolding self-blamers and how they direct their shame. So retributive self-blamers are going to see their behaviors fixed. They're going to focus on condemning themselves. They're going to be concerned only with past behaviors, and they're going to punish themselves for it. So they're going to direct their shame very negatively. Whereas scaffolding self-blamers are going to direct their shame towards making amends. They're going to see themselves as being capable of transformation and reform, and they're going to scaffold themselves to being better. And so scaffolding self-blamers can use their shame to motivate positive change, but this requires beliefs about self-efficacy. And so these authors also argue that it's important to respond to those with SUDs who are experiencing shame with constructive reproach that's going to utilize empathy, compassion, and understanding while still acknowledging their personal responsibility and the negative impacts their behaviors have had. And they argue this is going to help promote scaffolding to positive change. And so they give some examples of people in recovery and their loved ones of putting forth those approaches. So what can we learn from all this? So there's substantial evidence that shame can play a positive role in reducing a variety of detrimental behaviors, but there are practical and moral concerns against using shame. However, that doesn't mean that we shouldn't conflate that with the fact that negative feelings of shame can emerge from saying that a behavior is unhealthy or saying it's tied to an individual choice. Like that alone isn't morally, like that shouldn't be a reason to stop giving these information and educational campaigns. And so it's also the case that public health campaigns that focus on individual responsibility, that's important because there's evidence that self-efficacy, autonomy, and control is benefit for recovery and positive change. And so the claim that the structural changes are needed is right, but it's also important to note that communal norms about behaviors must evolve. And shame might play a positive role in that. Communal shame might play a positive role in that. And so we're advocating for this kind of balanced perspective of shame and public health. So you shouldn't explicitly shame, but the unintentional shame that might come about from, focusing on individual responsibility, that can still be acceptable and important for motivating change. The key question is what factors can facilitate leveraging the inevitable shame into positive motivation. And so the emphasis should be placed on the possibility to change and the resources that we need to provide for the change. And so shame is part of human experience, but it should be met with optimism, compassion, understanding, and the promotion of self-efficacy. And that's most likely to occur in context of mutual trust and respect. And so communal shame might be an effective tool for changing norms about eating if it takes a constructive approach and is implemented alongside structural changes. So some other questions to consider as well when figuring out the proper way to address obesity and public health, but we'll leave that for now. Thank you.
Thank you very much. Okay, questions?
Hi, my name's Jenny. I'm a PhD student at Kingston University in London, and thank you very much both for your presentations. I'm particularly interested in weight stigma, and I'm a midwife, so I'm looking at pregnancy. So I'd love to read your presentation again and read your references, but I suppose my fundamental belief is that you can't shame someone into losing weight. I think people of a higher weight fully know the size they are, and there are really complex reasons for that weight being higher. It could be genetics or illness or trauma. So I suppose that's my standpoint on this. But I also wondered about the weight loss injections and whether you think that shame will be increased as they're so they're freely available if you can afford to buy them outside kind of medical care, I guess. But whether you think these injections might make the shame higher or reduce it. I'm just interested in your opinions on this. Thank you.
Yes, that's it's a really interesting question. So I'm also really interested in the new weight loss drugs. And my thought is that it's actually going to perhaps decrease the amount of shame related to weight, just because I think what those drugs ultimately emphasize is that there is so I'm really interested in the food noise phenomenon that the drugs seem to be affecting. And so I think what it shows is that people have these individual differences in how they relate to and experience appetite and just drive for food. And I think that's something that was really underappreciated and made it seem more like it's solely the individual's fault. Like they're just lazy and gluttonous. They can't control themselves. That's why they're fat, right? And I think what these drugs are showing is that there are these kind of very individual differences in just the amount of hunger people feel, the amount food occupies their psychology. And that's what makes it very, very difficult to control their weight. And so I think as people kind of realize this food noise phenomenon is something that's going on in the very much in the background and consuming the background psychology of many people who are overweight, I think there's going to be actually less of stigma.
We've got one online question.
There's several online questions. The first one is from Becca, and she asks, what about shame, unconscious or reflexive shame being the motivation or reason that people pick up or use or reach for substances? So shame driving addiction, I suppose, is the question.
I guess I could just say, I think that's right. So I can't remember their name. It was Snoke et al. But So there's like different ways when you look at like the research, and part of it is like a conceptual issue about what gets called shame, what gets called guilt, and then sometimes there'll be a label of like toxic shame versus something else shame. But I think like what they're getting at is that I think that that article Snoke et al. really captures it. Is I think when you're engaged in a bad habit, it's inevitable that you're going to feel negative feelings. Some of those will be shame. And then the question, so I think that's inevitable, and it can have a worst effect, but it can also have a positive effect. And so what are the mechanisms that leads to benefit and negative? And it seems like one, it being in like cashed out in the right environment that's like supportive, and also that it's presented in a way that makes change possible. So I think like the position we're trying to argue for isn't, I don't think it's like pro shame, but it's also not negative shame. It's how do you redirect this emotion that's going to arise inevitably towards something positive. And I think, yeah, I doubt like some abstract entity like the government shaming you can do that, but perhaps someone talking to you or that you trust could. It's not that they're shaming you, but feelings of shame probably will arise.
Hi, I'm Anna. I'm a paediatrician. I'm really interested in childhood obesity, but I'm also really been thinking all day about the difference between guilt and shame. And guilt, so my knowledge comes largely from Brené Brown. I'll just put it out there. So she says that guilt is I did a bad thing, and shame is I am a bad person. And there's something around the addiction literature that you mentioned that was really interesting to me in terms of the scaffolding self-blamers. I would suggest is perhaps more guilt, and the retributive, I can't get my words out, self-blame as being more shame. Is there something about separating the behaviour from the person, even if that's just a really small gap, that potentially involves more motivating change? So instead of I am a bad person, to your point, so therefore I'm going to do bad things to myself, rather than actually there's a little bit of a gap. I guess is guilt more of a motivator than shame? And I don't know if that's too simplistic.
Well, I think that's right. Not thinking of yourself as a fixed thing, like I'm stuck with these past failures. But I also think that guilt and shame apply to different objects, not just like the person versus. So for instance, like if like I might not feel, I mean, they can come in different degrees, right? So like I feel guilty that I didn't pick up, someone from work that I promised. I also probably feel a little bit of shame, but I also feel ashamed. I don't feel guilty that I failed the test, but I feel ashamed that I did. So I think that it's pretty complex. And I think one thing I liked about that Snoke et al. Article is that, probably saying the right name wrong, but is that they kind of reject like guilt good, shame bad, and try to like explain it in a different way. But I don't know if Sarah maybe has anything.
Yeah, I think, it's in the psychology literature, there definitely is like the long history of like distinguishing guilt and shame, and for just the same reason you say, like one's about the behavior, one's about the self. I think, it's very hard to capture that difference. Like conceptually we can tease them apart, but like phenomenologically as an individual, I don't know how much they're being teased apart. They get used interchangeably by people talking about their experiences for sure. But I think, you might, in one sense, you might think like, if shame is the thing that's about the self, it could be more of a motivator for change because, once you realize like, what type of person do I want to be? I don't want to be this type of person, right? And so you might think shame is actually like really going to be like, it could possibly be leveraged in a way to like really make a transformation of the self. And that's why like the sort of scaffolding approach is so interesting and important, because you have to like realize like there's a type of person I want to be, and I'm not like the shame is telling me that I'm not being that type of person, right? I'm being a type of person I don't want to be. And so, you know, you can kind of use that as an indicator that you're not living up to the ideals you want to be. And then hopefully, with the help of supportive people around you, get yourself to change into the type of person you do want to be.
We've got questions here. Did you want to take some more from the? Okay, we'll take some online and then.
There's several questions and comments in the chat, but I think the speakers can see the chat. So if I don't get the chance to read them all out, perhaps
we can't see this
chat. Perhaps that can be made possible. But we can send you the questions in case I don't get through them. The next question in the queue of questions is, I'm wondering if you've noticed significant differences in the stigma associated with traditional cigarettes versus e-cigarettes and vaping.
I mean, I don't think as much research has been done on the e-cigarettes yet, although I did see some stuff, and honestly, I don't know. And then it seems like now the new thing that's popular is Zyn, like the nicotine thing. I don't know what it is, but so yeah. I mean, I do think it's kind of interesting how at least in America, smoking cigarettes is not cool generally, but it was like then vaping or e-cigarettes, and now it's something else. So I guess it's just like a war against these companies.
Well, I think, I mean, I do think the stigma of smokers being like stinky and unclean, you know, that really does, I think, push the like it's uncool to smoke. But like with e-cigarettes, you don't get like the stinky, like there's not like I don't think that stigma has yet like kind of formed with e-cigarettes. But yeah, I mean, I think it'll be interesting to see how it evolves.
Okay, I think we've got time for one more question, and then I think we take time for break. Now, who was first? Yeah, okay.
No, it's just thank you. I'm Andrea, child and adolescent psychiatrist. It was really helpful that you touched on the complexity of obesity, right? So, you know, you touched on some of it's invisible, there's biopsychosocial kind of factors, and also I think systemic factors. So in the UK, for example, a lot of eating disorder services are not commissioned for binge eating disorder. You know, there's, and we know that things like ADHD have a higher prevalence of binge eating disorder. So there's lots of stuff to think about. But I thought what was really interesting was the South Korea comment and community. And it reminds me of this meme that popped up, this video that popped up for me on Instagram of a Caucasian white obese male using a piece of gym equipment, and a black male in the same gym went up to him and could see that he was using it incorrectly and kindly said, "Can I help you out, mate?" And he said, "You know, this is how you'll have a more effective, you know, time with this particular gym equipment." And it was a really lovely interaction on YouTube just about kindness. And I think where you talk about South Korea community can use shame in a way that does affect weight. I guess that community is more homogenous. They might share the same values. They're less individualistic, right? So I think is part of the challenge, the fact that, you know, a lot of our society is very individualistic and very diverse. So how do you use shame in such a population where it's incredibly complex? You know, the richest can afford the drugs that are coming on the market now. Poverty clings to obesity. You know, mental health drugs cause weight increase. You know, it's so complicated and so challenging in that kind of situation. So.
I think that was.
Yeah. So,
I just say I just think that like really summarized like I think like what we're trying to get at nicely, and I would just say like maybe one of the lessons to take from that is like because you know we live in a like pluralistic, diverse society. I do think like the shaming of like that went into like vaccines and mask wearing was disastrous and has led to like more distrust. And I think that's because it was like presented by people that from groups certain people already didn't trust. And so I think that some of like points to some of the danger, right? But Sarah, sorry.
Oh, no, I was just gonna say, like, so in South Korea, like, I don't think that they're shaming in like a good way. Like, I think there's a lot of, there's like, oh, it's like almost it's like too much focused on appearance and stuff. So I don't think like I don't want to like claim they're like a model for how we ought to like control obesity, but I do think there is something about how they are willing to say like, maybe you're eating, like maybe like your portions are too much, or like maybe we eat this instead of that. Like I think like being able to like talk about healthy eating, I think that is like there is like a tendency to like not have that be out in the open in our culture. And sometimes you're even like made fun of if you're like, I'm not gonna eat this and like I'm not gonna eat this like treat or whatever. And so I think like maybe having just like not like explicit shaming, but just saying like having more norms about saying like, oh, I'm really enjoying this healthy thing. I'm not gonna eat this whole bag of Doritos or whatever, might be part of the way forward. But yeah, I think the fact that it is like such a pluralistic society does make it complicated, and it makes it hard to shame in a way that's not going to be overtly harmful.
I think that's all time we've got for the two presentations. Let's say thank you to them. If we take a 15-minute break, come back at 4:45. Thank you.
Yeah, I actually think all the drugs might Replied.
Okay, then if we start again. Louder. Okay then, if we start again. Shout it, scream it a bit. So. Okay, so this afternoon's, the final session, panel session this afternoon is on narrative medicine, shame and narrative medicine, and we have just the one paper being presented this afternoon by Dr. Karen Gold of the University of Toronto, and it's on narrative medicine as an antidote to shame, a close reading of a poem about chronic illness. So I'll hand you now over to Karen.
Thank you so much. I'm just going to share my slides, and if somebody can let me know, somebody can unmute and let me know if there's any problems with them, but hopefully you can see my main slide here. So I want to talk to you about narrative
Sorry,
medicine.
Karen, not at the moment. Oh, there we go. Yeah, hang on a moment.
Yes? Yes,
Yep.
you can see that okay?
Yeah, we can now.
Okay, perfect. Thank you. So I'm going to talk to you about narrative medicine. I'm actually going to do it by talking a little bit about the connection between shame and chronic illness. And then I'm going to actually sort of try to demonstrate narrative medicine. So we're actually going to do sort of a version of a narrative medicine exercise, which is called a close reading, which is basically a reading and reflection and discussion. And I'm going to sort of take you through that process, and then there's going to be an opportunity for some reflections, some discussion at the end of that. I work at the Narrative-Based Medicine Lab, which is actually a continuing medical education or professional development program at the Faculty of Medicine at University of Toronto. So we work primarily with clinicians, but we also have scholars and artists and other people that come that are just interested in this whole field of narrative healthcare or narrative-based medicine. So I want to start off just grounding our discussion a little bit in the relationship between illness and shame, and in particular chronic illness and shame. We know from the research that illness in general is often associated with shame-based emotions. It's often associated culturally with weakness, with a sense of being defective or being broken in some way. Shame tends to stick in particular to what Leahy calls energetic failures of the body. So being tired or being slow. Chronic illness in particular, because it's ongoing, is very tangled up with our sense of self. It's very hard to separate chronic illness and disability from our core identity, our sense of ourselves. Shame for people living with chronic illness or disability is extremely prevalent. I thought it was interesting that some research done on this peer online chronic illness community suggested that 70% of people there report experiencing shame on a daily or weekly basis in relation to their condition. We also know, in general, that shame is a social emotion, that it is produced as well as anticipated in social and interpersonal spaces, and therefore really impacts profoundly our social bonds with other people. Invisible illness and disability can create sort of a unique sense of anticipated shame or a sense of difference, and can lead to a sense, to want to hide or to isolate. This is particularly important, I think, because chronic illness and the shame that that produces can really impact interactions in the healthcare context. It can be experienced as judgment. It can be experienced as a fear of judgment, negative judgment. It can be also experienced by patients, sometimes as anger, which some authors have suggested is really a shame-based emotion in the context of healthcare. This was an interesting note, I thought, by a therapist who was trying to understand living with chronic illness and shame. She said, what happens when shame is triggered not by something we do and therefore can correct, but by who we are and cannot change? What happens when we are ashamed because we are ill? And sort of suggesting that idea that chronic illness is something that we live with. It's not something that we can sort of escape from or shift in terms of the core experience of that. So what does that mean? What does that mean for people living with chronic illness or disability? I want to introduce the whole idea of language and narrative medicine, which is using literary methods often of reading and writing and storytelling. How can we use it as a tool to sort of shift the dominant narrative a little bit around chronic illness and shame? Because we know that shame is an emotion that can be very hard to articulate, it's an emotion that can be very hard to uncover and sort of tease apart. So it's very important that we find language and we find ways of putting it into words. And, you know, certain scholars and authors have suggested that our understanding actually of chronic illness can be really shifted, or what Stage calls re-scripted, through story and through storytelling, through the intentional use of storytelling. And Marini also found that, you know, soliciting patient narratives and circulating them can also help us break some of the silence around what the lived experience of chronic illness is. So my main, you know, sort of question and interest is, how can we use narrative and narrative medicine, reading and writing and storytelling, to create some kind of counter stories, to shift the narrative so that we give voice to the more complex lived experience of chronic illness and start to provide some alternative accounts of this experience. So I love poetry, and my background is in poetic inquiry, and I love to use poetry as well as other kinds of texts when I'm doing narrative medicine facilitation and teaching. This is one of my favorite poems. Some of you may recognize it or recognize the author, but what I like to do is just dive into the poem itself. So if we were in a room together in person, I would probably read this and then have somebody else read it aloud, but I'm gonna read it aloud, and you can just listen at this point and follow along on the screen. It's called Wonder Woman by Ada Limon. Standing at the swell of the muddy Mississippi, after the urgent care doctor has just said, well, sometimes shit happens, I fell fast and hard for New Orleans all over again. Pain pills swirling in the purse, along with a spell for later. It's taken a while for me to admit I am in a raging battle with my body, a spinal column 35 degrees bent, vertigo that comes and goes like a DC Comics villain nobody can kill. Invisible pain is both a blessing and a curse. You always look so happy, said a stranger once as I shifted to my good side, grinning. But that day, alone on the riverbank, blaring from the steamboat Natchez, out of the corner of my eye, I saw a girl, maybe half my age, dressed, for no apparent reason, as Wonder Woman. She strutted by in all her strength and glory, invincible, eternal. And when I stood to clap, because who wouldn't have, she bowed and posed like she knew I needed a myth. A woman by a river, indestructible. So I'm going to actually give people a moment to just look silently at the poem. And I put 3 questions at the bottom for you to just reflect on. If you want to just think about them, if you have something you want to jot them down on, you're welcome to. The first question is, what images or phrases jump out at you? What resonate with you? What strike you? Who is in this poem? What are like the characters? Who is the narrator talking about or referring to. And what is the role of Wonder Woman at the end, do you think? Why does this poem end with her? So I'm just going to give people a moment, about a minute, to just look at the poem again silently and sort of maybe reflect on these questions. Okay, so that was a minute. If you are at your computer and you feel comfortable, I would invite you to share anything in the chat about either images, phrases that jumped out at you, anything that came to you when you were sort of silently rereading this poem to yourself, about the poem itself. If we were in a little bit of a different setting or a smaller group, we mainly teach online at the Narrative-Based Medicine Lab. So I would ask people would invite some of their responses in the chat. I would also open it up for some sort of open discussion at this point around, what do you make of this poem? You know, first of all, what is happening? And then how does this poem land on you, right? What jumps out at you? One of the principles of narrative medicine training, and the reason we do it actually in groups, is because we are trying to surface different perspectives. We are trying to cultivate perspective taking, as well as have a really sort of empathic, deep attention to the text, to the poem. So, oh, thanks, Emily. Emily said, first question, a woman with chronic pain, like fibromyalgia, maybe. Interesting. So yeah, of course, also our mind goes to, what is this about? Especially if you're not familiar with the author, Ada Limon, you might be thinking, what is she referring to? Could be fibromyalgia, something, something chronic. She has pain pills. She refers to it as invisible pain, being both a blessing and a curse, which is also interesting. She's in a raging battle with her body, is what we know. She has a spinal column 35 degrees bent. She's got vertigo. Ada Limon has also written and spoken quite publicly about her experience with chronic pain, disability, her struggles with infertility. And so she's written and spoken quite publicly about her health issues. But of course, the poem invites us to ask, what is it that's going on with her? I wanted to share with you, and also, I don't know, people are thinking about characters, but it's interesting to me. There's obviously the narrator, the voice in the poem, who's standing at the Mississippi, at the river in New Orleans, and has just been to the urgent care And I think it's interesting that just in a few lines, she captures something really interesting about the visit to the urgent care center, where I would imagine she got the pain pills, and the doctor saying, well, sometimes shit happens. And that's a very interesting discussion point for me to ask people, what do you think about that interaction with the doctor? You know, and get varied responses to that. Sometimes you go, oh, that sounds really dismissive, or I don't like that. You know, I actually find it kind of endearing, actually. It sounds to me like an interaction that perhaps was just very straightforward and open. We don't know for sure, but the point of narrative medicine is to use the text as a jumping off point for our own thoughts and reflections and discussion. So I'm going to share with you some commentary that other people have made on the poem. And Patricia Tuma is the poetry editor at the podcast On Being, and often brings up poems. Oh, I just saw that there's some more comments in the chat from Becca. The myth of coping, the surrender to become indestructible through breaking. Very interesting. So it raises issues around coping with chronic illness. Interestingly, the idea of surrender and the idea of being indestructible and breaking, right? Those two ends of that continuum. And Philippa, as a disabled, chronically ill person, I approached it with some caution that it would be a super trick type narrative. So I like that it ends with indestructible feeling more like a myth. Very interesting in terms of what kind of narrative does this poem communicate. And in narrative medicine, we also spend time thinking about what are the kinds of narratives of illness and disability that are circulating in our culture, and what is that like for people who are experiencing that, whether they fit into common narratives or they don't fit into common narratives. So I like that you raise the issue of like, what kind of story is this? What is it that the narrator is actually saying? And from Bonnie, I feel it is more of a fantasy to be Wonder Woman. Yeah, so the poem takes us into this realm of myth and fantasy. And I'm going to talk a little bit more about that. Thank you so much for those comments and reflections. You can hopefully see that when people respond to the poem, it starts to make the impact of the poem and the meaning of it quite rich, because we're bringing our own perspectives and experiences to it. So Patricia Tuma said, the story of the poem is that she's in New Orleans and an urgent care doctor has just given her a message. And now she is standing at the swell of the Mississippi River. And it seems to be that she is coming to some kind of realization about the story of her body, the story of her, quote, raging battle with her body. Pain is everywhere in the poem. There's a doctor that she's gone to seek help from, or the urgent care center. There's pain pills in her purse. There's even pain pills for later because she anticipates needing them. And then he says, anyone who has lived with chronic illness will know that A, you are living with your symptoms. B, you are living with other people's impressions and reactions to your symptoms as to whether you should or you should not be sick, as to whether you should or should not be on medication, as to what you think, as to what they think will help you, as to whether they think the severity of your illness corresponds to how you narrate it or not. And that can be a burden on top of the question of living with your own maladies. So he's very much centering us on the response of other people and the response of people to sometimes what we call invisible illness or disability, and other people's judgments or anticipated judgments of that. So a little bit of background, and for those of you who are not familiar, Wonder Woman is a superhero from DC Comics, the US-based DC Comics, created by a psychologist, William Marston, in 1941. And she has superhuman gifts. Her origin story is that she is from the Amazon, and that she has superhuman gifts granted to her from the Greek gods, which are strength, speed, the ability to fly, the ability to heal others, the ability to engage in astral projection, and she is also able to speak and understand any language. She has magical items from Amazonian technology, which include the lasso, the rope that she carries, which is the lasso of truth, a pair of indestructible bracelets, which is how I often think about her. She wears these large bracelets, which she can fend off bullets and other things. And she has a tiara, which also serves as a projectile. So she's armed with this superhuman qualities, but also this technology, these tools. And what Otuma says about the poem is that it is the story of a person living with an invisible chronic disability or chronic pain who finds unexpected fortitude from a girl dressed as a superhero. Their encounter, which of course is silent, there's not any verbal communication or interaction between the two of them other than perhaps a nonverbal when she looks at her. Their encounter at the swell of the muddy Mississippi River doesn't have a fantasy ending, but instead finds strength and glory in bodies and in myth. So interesting, speaking to this whole idea, somebody commented, does it leave us sort of on this level of sort of fantasy? And of course it is drawing on fantasy and myth in the form of a, popular culture, a superhero. But he's saying it also ends leaving us on, where do we find strength? Could we find strength actually in looking at myth and mythology? This is an interesting aspect of the poem to me. And I just wanted to point people to the role of popular culture and superhero in narrative-based medicine, but also in coping with illness. Some people may be familiar with the field of superhero therapy, which was developed by a psychologist in the United States named Janina Scarlett. And it is something that is used with other kinds of therapy, like CBT and other forms, where there's discussion around, are there figures from popular culture? It could be from comic book, it could be from a TV show, it could be from a movie that the client or the patient is drawn to, identifies with. Janina Scarlett was, as a child, was a victim of Chernobyl, and she had radiation poisoning and was very ill as a child. And she sort of discovered the power of superheroes. And then when she became a psychologist, she was working around a lot of PTSD with military veterans. And she found that discussions around figures from popular culture, comic books, was a very, very helpful way to explore some of the people's issues. They are a form of contemporary myth. You could argue these are our myths. They can be a source of strength. And she argues particularly superheroes, because all superheroes have a vulnerability, but they also have superpowers. And she's written, my life forever changed when I saw my first X-Men film. The X-Men are Marvel superheroes. They all have some kind of genetic mutation. Many of them have been exposed to radiation and also have been bullied and ostracized. So she very much related to them. And now she's sort of trying to harness the power of that to help people deal with illness as well as psychological struggles. So I want to sort of bring us to perhaps some reflection on, well, how could this be used? What are the implications of this kind of narrative medicine activity, this kind of training, to address shame and chronic illness. I think for me, one of the important things is, as other people have talked about, being mindful of how shame operates in illness, and in particular in clinical interactions between healthcare practitioners and patients. And I would say being mindful of how shame might be operating for patients and for family members, as well as for clinicians, and how that might be operating in a particular interaction, to just bring some awareness to it. And think about how, by what we say or we do, we're mindful to not perpetuate that unintentionally. I think it also can be so valuable to bring people together for opportunities to read and to reflect on texts like we just did. And that could be groups of patients, groups of trainees, as well as groups of healthcare practitioners and clinicians. I think it can be so important to share stories of other people who are experiencing, in this case, perhaps chronic illness or chronic disability, chronic pain, to reduce people's sense of isolation. I would be very interested in some of your thoughts, not only on the text, but also how could this kind of text or this activity be utilized to address shame in the experience of patients, but also in healthcare interactions, and in shifting some of our understanding of the day-to-day lived sort of complex experience of people with chronic illness or disability or chronic pain. And if we were doing like a full narrative medicine session, just to give people a sense, and I'll offer this to you if you want to do a couple of minutes of writing after the session, is I would also give people an opportunity to reflect in writing. And usually that's in very short prompted writing activities. I might give somebody 2, 3, 4 minutes, 5 minutes, it's not long, but I would try to extrapolate some of the themes or things that might be of interest to people in the text. So I might say, write about a superhero, write about something that gives you strength, write about an exchange with a healthcare practitioner, either from the perspective of being a patient or the healthcare practitioner. Write about a river. You know, the river is such a, I think, sort of a vivid and beautiful piece of her, of Ada Limon's poem, and is, you know, makes the poem very visual. So you can draw out anything, things that are more concrete, things that are more abstract. You can ask people to reflect on it in writing. And in narrative medicine sessions, then we also give people an opportunity, if they feel comfortable, to share their writing or share some of it. So those are some references. If people are interested, they can be in touch with me. But I'd just like to open it up for some questions, thoughts, comments. If you want to put it in the chat, or I don't know if people can unmute. I'm not sure what the best way is to do it, but any reflections on either the text or, sorry, I'll go to the end, or the use of this kind of, narrative medicine training.
So thank you, Karen. We'll now open up to any thoughts or questions. So anybody in the audience? Yeah.
Thank you, Karen. Really enjoyed that very much. I am here in Exeter, but live across the lake in Rochester, New York. So
Oh, okay, so not far from where I am. Not
That's right.
Just across the lake from Toronto.
That's right. Yeah. So a couple of things. One was my reflections on the text, especially the question about the role of the characters in Wonder Woman, and then also implications and how it could be used with shame. An image that came to me as we went through the text was Frida Kahlo, especially the broken column. You know, she has a painting of the broken column, and then having such chronic pain, and then actually the creative act of painting and maybe creating an image of oneself with the column. I don't know if you've seen that painting, but
Yes.
it almost looks
definitely.
like that image that you just showed of Wonder Woman with her hands on her hips and standing resolute and strong and looking very directly into the person looking at the painting, but with this, really messed up spine. And one of the things that came to me was that, that image that one can create for oneself or find it through text in a narrative, in a poem or whatever, could be a very helpful counterweight to, all the other experiences of shame with living with chronic pain and a chronic condition, as she did, of course. And I think she lived and painted in the 30s, 40s. So kind of the time frame was very similar. It's really interesting. I'm also thinking about, the, saving that can be save oneself in terms of one's well-being and self-image, almost like a tragedy, of course, and then being plucked out of that through the Deus ex machina technology of, an image like Wonder Woman or of the broken column painting. So just comments on that. Thank you.
Yeah, thank you so much. Well, you raised a couple of really interesting points about this text, but also narrative medicine, because text in narrative medicine is very broadly conceptualized. So it can be, of course, written text, but it can be a visual text, like a painting or a piece of art. It can be a film clip. It can be a piece of music. So we have a very broad definition of text. And I love that you raised Frida Kahlo's work. I have actually used her images in narrative medicine training. I find them very evocative, very powerful. Just as you said, to open up some of this discussion and reflection. I never actually thought about specifically pairing Kahlo's painting around her spinal. She did a series of paintings around her spinal surgeries with this text, but I think that's a really brilliant pairing, actually. And I'm thinking I would love to try that because there's so much, in literature, what we call intertextuality there between that painting and this poem. So I just love that. So yeah, thank you for that comment.
Any other thoughts or questions? Yeah.
Hi, this is Diane Obang from Edmonton, Alberta.
Oh,
and I am
okay.
in Exeter.
Hello.
Yes. Hi. So I really appreciated the talk, and I think storytelling can be a really effective way of getting people to talk about shame. We've been talking today about, how do you teach that when nobody really wants to come to these sessions, these workshops on shame? I think this might be a way to really have our participants or learners open up, because it's really a lot about self-reflection. And just as one of the older people in this room, I think, yes, the poem, what meant to me, I don't have a chronic illness, but I have a chronic aging thing going on, and the image of the young girl at the end, and it was really, to me, it was youth walking by me and saying, yes, I'm strong, and it's saying, okay, there's a reason why I'm here and she's there, but go girl. So that's I don't know if you've ever had that kind of interpretation of the poem.
That's a really interesting interpretation. Yeah, I mean, it just adds another layer, doesn't it? There's been some really interesting discussion in groups around that figure of Wonder Woman at the end. I've even had people say, oh, I think it was the narrator herself. Like, it's very interesting. It provokes a lot of different interpretation. But it seems to be a very powerful image. And it's sort of a powerful way to end the poem. Somewhat ambiguous, as people have pointed out, like, is it ending on a note of fantasy? It's sort of bringing in fantasy and mythology, but also in a way that fortifies the narrator, like almost like the narrator is borrowing some strength or something, which I find sort of interesting. You mentioned using storytelling with learners. So that's a real interest of mine. I think that one of the things that can be helpful around this kind of close reading of a text, a painting, a poem, is that it can be less threatening and less intimidating to talk about than asking learners to reflect on their own experiences, which also can be done, I think, in narrative medicine. Just you have to sort of curate that, I think, carefully. But I think being able to talk about the narrator, this woman standing on the banks of the Mississippi River, what do you think she's experiencing? What do you think that encounter in the urgent care center was like for her? What do you think was going through the mind of the doctor? That's a very interesting conversation to me that might flow out of this text if I was working with medical learners or learners in health professions. You know, what do you think that clinician might be thinking? You know, this woman presents, probably doesn't know her at all. It's an urgent care center talking about she's in chronic pain, she needs pain pills. So that can lead into an interesting conversation around our responses and our attitudes in healthcare around people that are seeking pain medication. So I think in terms of learners, there's a lot of interesting, rich discussion. Then you could, you know, potentially ask them reflect on an encounter you had of the patient, maybe that, you know, reminds you of this, or you know, who can also relate to the idea of a superhero. Do people have a superhero? You know, if I said, think about a superhero, somebody that you read comics as a child, or you watched on films, or something that you either are drawn to or relate to. Janina Scarlett's work on superhero therapy is so interesting because she talks about the range of characters that both adolescents and adults are drawn to. Both popular TV shows, comic books, there's a wide range. And these very rich discussions she has around what draws you to that character. And very interesting to see the points of connection that people feel to figures in popular culture. So it's sort of really harnessing popular culture. And there's been some interesting work on that as well in healthcare around harnessing popular culture in pediatric settings, using it as a common focal point to talk to children and to talk to parents. So that opens up that whole area in narrative medicine too, is the use of popular culture. What are the stories that circulate in popular culture? And are there ways that we can sort of harness that as well? So yeah, thank you for your comment. And the aging piece is interesting as well. I think there's so much resonance with this around such a continuum of experiences, whether it be disability, chronic illness, pain, aging. You know, I'm curious about that idea of the energetic failures of the body. I was reading that in one of the research studies around chronic illness and shame, and I thought that was such an evocative term. It basically means bodies that are tired or lacking in energy, which could relate to a lot of chronic disabilities, but also could relate to aging.
Yeah. Karen, can I
so
come
it's
in?
A very interesting overlap.
Karen, can I come in? I'm Anna. I'm a paediatrician from Somerset in the UK, so I don't live very near you, I'm afraid. Not like many of my lovely colleagues in the audience. So I was really interested with my doctor hat on, so as a doctor, that what opens it up for me was when she's reflecting on the urgent care doctor saying, well, sometimes shit happens. That's a beautiful conduit into what are the worst things you've said as a doctor. Because some of the things that we reflect on, some of the things that give us the most shame in medicine is the things that we really wish, like in retrospect, that we hadn't said. And so much of that goes unsaid. And there is so much wonderful learning to be had from sharing, you know, whether those are unkind comments, whether those are unhelpful comments, whether those are racist comments, whether those are whatever it is. There is so much learning to be had from sharing the worst things that you have said. And I just thought that was a really beautiful way, because how do you even begin to approach that in a reflective session? You know, if you stood up in front of a group of junior doctors, senior doctor students and said, what are the worst things you said to a patient, you wouldn't get very far. Whereas I think this poem was a beautiful hook in. So for me, I'm going to try it, because actually I think it's a really lovely way of introducing it. And to your point, sometimes some of the things in our head that we think were an awful thing to say, actually sometimes the patients, either they're very generous in their response to us, or they say, do you know what, I like a doctor that calls a spade a spade. Thanks for saying it like that. So actually sometimes the response is not necessarily what, you wouldn't necessarily say the same thing again, but sometimes it's received with a grace that perhaps, it is quite useful.
Thank you so much for saying that. I think there are so many teachable points in this, teachable moments. I think that exactly as you're saying, the text is an opportunity to surface different responses to that conversation in urgent care, which, as you said, some people could find. I've had people say to me, that's awful. I can't believe the urgent care doctor said that to you. That's terrible. And I've had other people who are like, I don't know, I find it kind of refreshing. Like, I kind of like when my doctor's kind of human with me. So it surfaces different responses, which I think is a very valuable learning. But I love the idea of using this as sort of what we call in narrative medicine, a prompt or an opening for trainees to think about what is the worst thing that either you've said or you've witnessed someone say. And that, as you're saying, is such a source of shame for healthcare providers themselves, that this would be possibly a safer way to open up conversation around, what do you think about that? And how do you think that, physician in the poem might have, why do you think the physician might have said that? How do you think they might have felt afterwards? How do you think the narrator felt about that? You can surface all of these conversations. And you can also potentially ask trainees to reflect on an experience that they had as a patient or a family member, because pretty much everyone will have something, either their own experience as a patient or going to an emergency department with a parent or a grandparent or a family member. You can ask them to write about an impactful interaction with a healthcare provider, which could be positive or negative, but something that really stayed with them. You can ask the same of healthcare providers. So I love using it to get at some of those shame-based experiences for healthcare providers, for clinicians themselves. So thank you so much for raising that.
Okay, I think we have.
And if you do use it, I'm going to put my email in the chat. It's karen.gold@utoronto.ca. I don't know if people can see that or the host can share it, or you can find me through the Narrative-Based Medicine Lab. I'm going to just write that in, Narrative-Based Medicine Lab, Temerty Faculty of Medicine, University of Toronto. And I would love to hear your experience if you use this with a group of trainees or some colleagues. I would really love to hear how that goes.
So I think we have one more question.
Yeah, sure.
Thanks, Karen. I'm Andrew from King's College in London. There seems to be a persistently high rate of teenage boys suicide and young men suicide in the UK, and I think it's the same in many Western world countries.
Yes.
I was just wondering.
Stats are similar in North America.
Right.
Yeah.
I was just wondering if there's an approach that narrative medicine can be used, because a lot of work has shown that shame is the basis of a successful suicide. Because that half of the population are not the chirpiest and most talkative in general. So yes. I just wonder what your thoughts are and whether it's been a success.
Yeah, that's an interesting topic. I mean, the issue of young adult suicide and particularly young men's is so troubling. I think you're right. There's so many shame-based emotions going on. I think also from some of the research I've seen, it's feeling like a burden, feeling both hopeless, but also like a burden to other people, which is often a trigger, sort of final trigger. So I think about that. I think that one of the fields in narrative medicine that I love the most is the field of graphic medicine. And that is this growing body of literature that is like graphic novels, graphic essays, and particularly for adolescents and young adults, I think there's also a draw to that kind of text, maybe more so than poetry or, I mean, poetry can also be songs, popular songs and all of that. So I just tend to think that I'm not sure I've seen any graphic novels that deal with that issue. There's a lot of graphic novels now on mental health issues, written from the perspective of people experiencing chronic mental health issues, also chronic disability and physical health. So there's not anything in particular that I can think of, but I also think it would be a very powerful vehicle, because that's something that therapists and healthcare practitioners can also share with patients and clients. They can share a graphic novel as a way to reduce isolation, as a way to open up conversation around what somebody is struggling with. So I'm not sure if that exactly answers, but I think narrative medicine could be a very powerful tool to open up conversation, and at least to open up conversation, if you could find a story that relates to those themes, open up conversations also with therapists and healthcare providers around how to navigate these issues, with patients. If anyone does have any texts that they know of that address those themes, it would be really wonderful to hear about those or to share those.
Okay, I think we do have a few more questions, but I'm afraid we're out of time. So perhaps if you can send them across via email. Okay, so thank you to Karen.
Sure, thank you so much. Thanks for all your comments.
All right, before you stand up and start leaving, I'm going to say a couple of things. So thank you all for making it to the end of the day. I know me talking is what's standing between you and a glass of wine, so I'm going to keep this very, very, very brief. Just want to thank everyone, all the speakers and audience members, both in the room and online, and our tech team for making this run very smoothly. The talks have been amazing and really inspiring, and traversing so many topics and countries and disciplines and approaches, and yeah, lots to think about and lots of references to follow up. So I've been very inspired and impressed. So if you are coming for dinner tonight, it's in the hall, which is not on campus. Someone said to me, where is the dinner? Is it on campus? It's not, it's in town. And I think Alice has sent the address and directions. It's quite near 4th Street, which is the main street that runs through Exeter City Centre. Tomorrow we're going to start at 9:30, but I think tea and coffee will be available from 9, is that right? And the building opens at 8:30, so you can come anytime before 9:30, but the first talk will start then. And now we have a wine reception and some snacks and nibbles in the Queen's building, which is a very, very close building. It's about 3 minutes walk away. You kind of walk up out of this garden, turn right on the main road, and there's a kind of building that's got an outdoor cafe area, and the reception is in the inside of that cafe. And many of us from Exeter will be walking that way, so if you're not sure where you're going, you can follow one of us. And alongside the wine reception, we have the exhibition of the artwork that accompanied the Nocturnus podcast series. And it's an interactive exhibition where you can listen to clips from the podcast series if you have your headphones with you, while also looking at the beautiful images. So I hope you can join us for the snacks and wine now. And thank you all for being here. I'll see you tomorrow. Thank you.